Hello everyone, my name is Jasmine Martinez. The chapter that I will be discussing today pertains to policies that are implemented in order to contain costs. On the next slide, we will begin by going through an overview of the main ideas that are targeted throughout this chapter. The first main idea is the option that are available for policymakers to utilize in the controlling the rising costs and growth in the medical care system. This includes the utilization of the following global budgets, fee schedules, and resource rationing. After discussing the various options, this chapter will discuss the United States' current method in order to reduce the cost. Lastly, I will discuss the costs contained throughout the managed care and the market alternatives that are available. Moving on to the next slide. In order to understand the importance of creating policies to contain costs, we must first understand the effects of medical care cost rising. Medical care cost rising creates new difficult decisions when it comes to achieving consistency in quality, access, and cost. This is also known as the triple A. With the implementation of universal coverage, it has increased the access to guaranteed spending, three approaches that are implemented in order to rein in spending growth, which includes mandatory fee schedule, global budgeting, and resource rationing. We're going to begin on the next slide by discussing mandatory fee schedule. Mandatory fee schedule are usually the first approach to be used in the medical field and can take on two practices. The first being the price ceiling price freeze. Price schedules are commonly negotiated between the government and the representative of the medical community. They also attempt to place a value of services according to some comparative scale. Price control serves as a stimulus towards more efficient resource use. However, the result of mandatory fee schedule allows for a physician to induce demand, shifting the demand curve for services. The shift translates into less time being spent with the patient in order to increase more patients being seen and more follow-ups visits to be scheduled. The next practice that is utilized for price control is unbundling. Unbundling refers to the practice of breaking down a service into various component parts. This translates into the provider billing per each part of the treatment, which, in my opinion, this practice is unfair to the fact that paying for everything individually costs more than paying for everything as a whole. The next approach when trying to control spending leads me to the next slide regarding global budgeting. Global budgeting is utilized when mandatory fee schedule is unsuccessful, and we really don't want to jump right into rationing. So think of global budgeting as a spending cap, which can be established as a target or mandatory budget. A way that this particular approach is utilized is to set a global budget for hospitals, providing each institution to set an amount of money to be used to provide a service to all comers. If spending exceeds budget spending, then items are put on standby until the new budget is available. An example of this, if they already met budget, they will, in a hospital ward, will be closed. An operating room will not be used. And non-essential personnel will take time off with unpaid. In my opinion, this matter is that it truly possesses a question of ethics. In this source of pricing control, we are allowing monetary amounts to determine when a patient will be receiving the treatment that they need. The last approach that is utilized in truly a last resource measure, and this brings us to the next slide, is the resource rationing. Resource rationing is the last resource to use. This is actually used when mandatory fees and global budgeting is unsuccessful. Rationing limits access to the desired commodity of service. The first step begins with improving access to primary and preventive care by encouraging or possibly even mandating more physicians to practice primary and family medicine. To ensure cost containment, access to high cost medical technology must be restricted. Rationing takes the form of waiting lists and increased costs of travel to distant facility, especially for patients living in the rural area. Under increasing pressure to contain medical costs, physicians find themselves wondering whether it is ever proper to ration health care at the bedside of the patient. The fact that this is a concern for a physician leads me again to question the ethics behind pricing control. Pricing control approaches are questionable ethically, but are these effective in achieving the goal of controlling costs? The question leads us to the next slide. These approach for price control benefits in the sense of benefiting patients and the expense of providers for a short term. However, these approaches for price control have shown decrease in the areas of quality while increasing the cost. In the end, control actually increases the cost because the distortion created by control stifles in the innovative activities that would lower the cost. Until recently, governments had chosen the regulatory options, relying primarily on fee schedules and global budgets and resource rationing. The United States experience has been limited primarily to the state-con laws and Medicare price controls, including the DRGs for hospitals and the RPRVs for physicians. On the final slide, we will be discussing the next main ideas of Chapter 13, which is the United States experiences with the utilizations of different cost-saving methods. We will begin with the next slide discussing on diagnosis-related groups and prospective payments. To encounter the increased spending and growing inefficiency, federal strategies focus on cost containment efforts on the supply side, devising a prospective payment mechanism for the hospitals sectors. In principle, prospective payments will provide economic incentives and conserve scarce medical resources, which will in turn hold down the growth and expenses. Medicare initially set up a 467 DRG category based on principal diagnosis, age of the patient, presence of the comorbidity condition, use of surgical procedures, and discharge of status of patients. Prospective payments succeeds in reducing Medicare hospital expense. On the next slide, we will provide information on Medicare severity diagnosis related groups. Medicare severity diagnosis related groups redefines the units of measures used in determining Medicare payments. Charges are determined in advance on per case basis. The payment is based on a point system and is determined by a reimbursement rate that is referred to each case weight point. These relative weights are set nationally and adjusted for wage differences by location and a number of other factors, including the cost associated with graduate medical education, the share of low-income patients treated, and the cost of living. The equation used to calculate the payment is payments equal MS dot dash DRG case weight times adjusted payment rate. The following two slides refer to the setting physician fees, resource-based relative value score. The Medicare payment were limited to the minimum of customary, prevailing, and reasonable charges for a particular physician practicing in a specific geographic area. The customary charge is the physician's actual charge during the previous years, defined the median charge of the service. In 1986, Congress commissioned a study to determine the possibility of developing a resource relative value scale, which is the RPRVS. A relative value scale is an index of relative levels to resource use when physicians produce service or procedures. Although the relative value scale is denominated is non-monetary unit, the logical extension translated relative source used into a fee schedule. The Medicare physician payments is based on the principle that difference in payments should reflect difference in work effort. Physicians incur three types of costs to produce medical service for the patient. 1. Work effort measured by their own time, energy, and skill. 2. The overhead cost of the practice. And 3. The professional liability insurance premium. A fee system is based on the relative value scale and is designed to reduce the disparity between procedures and services. It also focuses on the time the effort involves in providing the medical procedures or services. The RBRVS could provide a fair and equitable approach to compensating physicians for the service they provide. By removing the distortion in current fee structure, the RBRVS will provide a neutral incentives structure for physicians making medical decisions by altering physicians' practice patterns. The rates of surgeries, invasive diagnosis tests, and hospitals' use could be reduced significantly. On the next slide, we will discuss the management care strategies. Management care strategy goals is to ensure the provision of medical necessary service on the appropriate settings and the appropriate levels and price. It restricts access to certain kinds of medical care, such as hospital and specialty care, to redirect medical care and delivery to access expensive locations. The next slide, we will review market strategies. The market alternative demand side strategies, which includes options to give the consumer's patient more responsibility in the decision-making process. The competition can also serve as a catalyst of innovative behavior on the part of providers to lower costs and improve qualities. After reviewing this chapter, my question to you is, resource rationing is the last alternative used in controls costs. Due to the fact rationing takes the form of waiting lists and increases the cost to travel a distance facilities, especially for patients living in rural areas. Do you believe that the resource rationing is an ethical method in order to control the cost? Can't wait to see your answer to this question. Have a wonderful day.